Welcome and thank you for listening to our lecture on advanced musculoskeletal imaging. The presenters during this presentation will be Lewis, Stephen, Chalerm, Dilshan and Aaron. In gathering evidence and research for our case study, we used a library database and search engines such as Cochrane, Sinal and Medline. We then broke down keywords such as heel pain, ultrasound and X-ray in conjunction with other keywords or as singular words. Continuing on, here are some of the databases we used. In the first picture it shows that we refined our search by using scholarly, peer-reviewed, and excluding newspaper articles. We wanted to find the highest level of research and most specific to our case. As you can see from the other two pictures of other databases, we included words that were relevant and excluded words that we did not want. Let's now move on to our patient Frank. He's a 52-year-old sales consultant who plays golf and is overweight. He has presented to the clinic with pain around his plantar medial tubercle of the calcaneus. From his medical and social history, our potential or differential diagnosis for Frank are plantar fasciitis or calcaneal stress fracture.
So in order to discover the provisional diagnosis, we needed to look at what the risk factors were for both conditions, as well as what the signs and symptoms are for each. We found that obesity was a contributing factor for both plantar fasciitis and calcaneal stress fracture. Our patient Frank is in fact overweight, so initially it is still evenly probable that he has either. The main difference between the two diagnoses lies in the risk factors in which each are obtained. We found that stress fractures can also be inflicted by continuous trauma or excessive use of the limb. An example of this may be playing a sport at a moderate to vigorous intensity. No offense to golfing enthusiasts, but golf isn't exactly a fast-paced, exhilarating sport, and bearing this in mind leads us to believe that it is less likely to be a stress fracture. The difference in symptoms between the two is that the stress fractures usually involve constant pain, whereas plantar fasciitis, the pain is inconsistent, usually elevating during times of prolonged rest or inactivity. After comparing Frank's situation to the risk factors and symptoms, it was decided that the more likely diagnosis is plantar fasciitis.
Now that we have the provisional diagnosis of plantar fasciitis for Frank, we can refer him either for an ultrasound or MRI. They are both very good diagnostic modalities for soft tissue pathologies. MRI is the gold standard diagnostic modality for plantar fasciitis. It has the highest sensitivity and specificity, both close to 100%. It is very safe because it is non-invasive and does not emit any radiation. It is also very useful in identifying other causes of atypical heel pain, such as bone marrow edema or calcaneal stress fracture. Ultrasound is almost as high in sensitivity and specificity as MRI for plantar fasciitis, with 80% sensitivity and 88.5% specificity. It has the ability for the radiographer to correlate findings directly to patient symptoms in real time during the imaging procedure. It is also very safe, quick, easy, less expensive, and rarely available, which is beneficial if serial follow-up imaging is needed. Since ultrasound is just as reliable in the diagnosis of plantar fasciitis, but with lower cost and the ease of future follow-up comparing to MRI, we have decided to refer Frank for an ultrasound instead of MRI. This is a very high-quality Level 1 systematic review by Macmillan et al. In 2009, which meets all the criteria in a systematic review appraisal sheet and also included 23 studies. In the review, they have found two main ultrasonography diagnostic signs of plantar fasciitis, which will help us to confirm Frank's diagnosis of plantar fasciitis. The first sign to look for is proximal plantar fascia thickening. If Frank has plantar fasciitis, his proximal plantar fascia will very likely to be thicker than 4 mm. The second sign to look for is hypoechogenicity, which is a darker image of his proximal plantar fascia on the ultrasound if he has plantar fasciitis.
If the ultrasound result is positive for plantar fasciitis, we have to consider treatment options. Rest, Achilles tendon and plantar fascia stretches, ice, non-steroid anti-inflammatory drugs are a good place to start treatment. Footwear or prescription orthoses may be prescribed, featuring some form of heel cushion and medial arch support and possibly addressing other foot pathologies. Low-dye typing to help support the fascia and corticosteroid injections to help reduce inflammation should be considered. If conservative options fail, we can refer the patient to a surgeon. If our ultrasound results are negative for plantar fasciitis, we have to consider whether to use X-ray, MRI, bone scan, or CT to test our differential diagnosis of calcaneal stress fracture. An X-ray isn't ideal for diagnosing calcaneal stress fracture. X-rays have low sensitivity, with the fracture unlikely to be visible until 2 to 3 weeks after the fracture occurred. Even after that, Dodson et al. Suggest that the false negative rate is around 50%. We also have to consider that even a low dose of radiation, such as in a foot X-ray, isn't completely safe. An MRI is considered the modality of choice for diagnosing calcaneal stress fracture. An MRI provides quick, relatively non-invasive, high-quality anatomical images that can be used not only to diagnose calcaneal stress fractures, but to help determine when the patient can return to activity. MRIs are highly sensitive, approaching 100% sensitivity in detecting calcaneal stress fractures. They are highly specific in detecting periosteal and bone marrow edema associated with stress fractures. However, these signs may be present in other conditions, therefore must be combined with a good patient history to achieve high specificity. Though there is no radiation exposure from an MRI, there is a small possibility of a hypersensitivity reaction to the contrast medium used. A 3-phase bone scan has a high degree of sensitivity to stress fractures, approaching 100%. However, it has a low level of specificity. It detects metabolic processes occurring in the region, but offers no information as to what is causing those processes to occur. In a bone scan, the patient is injected with a radioactive substance. As with X-rays, exposure to even a small level of radiation may be harmful, and a CT scan is not useful in detecting stress fractures.
Calcaneal stress fracture, MRI diagnostic signs. When looking at clinical evidence for diagnostic sign of calcaneal stress fracture, the systematic review of case studies conducted by Dodson et al. In 2008 explores several key features to look for while evaluating a patient for potential stress fracture using MRI. Early changes occurring during stress fracture are hemorrhage and interosseous edema. Therefore, it is important to make sure that the T2 fat suppressed images are taken first so that the bone marrow edema can be visualized. On T2 fat suppressed images, marrow edema will appear bright white, high intensity. Contrasts against a dark background of fat suppressed normal bone and soft tissue. With further progression of the stress fracture, the edema will visibly on T1 and T2 images. The T1 weighted images are also known as fat images, with normal bone appearing bright white. Interosseous edema appears dark, decreased signal intensity on T1 weighted images. The most representative picture of a stress fracture on MRI is decreased signal intensity on all sequences with a larger, poorly defined zone of edema surrounding the lesion. With moderate to severe stress fracture, an overt fracture line can be seen on both T1 and T2 images. However, this fracture line is especially visible on T1 weighted images, which are also the best image for viewing specific anatomic structure. So what's next if the results do come back for positive calcaneal stress fracture? Once we know the cause of pain, we can then start prescribing treatments for the cause. Firstly, you would ask the patient to rest at least a minimum of 1 week on bed. Duration of rest depends on the extent of the fracture. Then you would impose methods to offload the pressure from the fractured calcaneus. We can do this by having the patient walk with 4-point weight bearing crutches, or putting 0.5 cm sponge rubber under the calcaneus inside the shoe, heel lifts, strapping, or even ankle stirrup braces. Even though we reduce the pressure on the area, there will still be pain exerted from that region. For this, we can offer cryotherapy or non-steroidal anti-inflammatory medications such as aspirin. If the results were inconclusive, or there is no improvement from treatment, we would continue the ladder of mortality to find a further provisional diagnosis.
In summary of the above research and case study, we have formulated an overall flowchart or diagnostic algorithm. As from above, we emphasize the importance of interviewing processes and a holistic approach to a diagnosis. From the flowchart, you can see the first chosen modality is an ultrasound, followed by an MRI. These were found to be both sensitive and specific in diagnosing both pathologies. Importantly, the modalities chosen are considered the most sensitive, specific, safe, and cost-effective means in an effective treatment and diagnostic process. The top 3 in our overall modality ladder go from the ultrasound through to the MRI and then the CAT scan. Thank you for watching our presentation on advanced musculoskeletal imaging.